Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Good morning, dear excellencies, speakers, and participants. We meet again on the second day of the international webinar held by the Faculty of Veterinary Medicine, Universitas Airlangga, with a theme, Update on Veterinary Stem Cell, the state-of-the-art stem cell research for clinical application. My name is Hogalin Devi, and I will be the host for today. Yesterday, we've got new insights from Dr. Chan Pop and Dr. Chutirat from Chulalongkorn University, Thailand. And today, we still have our three resourceful speakers. But before that, on behalf of the committee, I'd like to express my gratitude to our Almighty God who have given us his blessings so that we can meet virtually in here. And also, I'd like to greet the Honorable Head of Divisions in the faculty, Dr. F.D. Muhammad Lukman. Hi. Okay, thank you so much for sparing your time to join us in here. And also, I'd like to greet our speakers for today, Dr. Chutirat Torsahakul, DPM, and Watchareewan Rodprasert, Bachelor of Science, Ph.D., and also Suryo Kuncorojakti, DPM, M.Vet, Ph.D. Thank you so much for sparing your time in here so that we can share, to have a discussions in here in this international webinar. It will be very helpful for all of us in here. And also, I'd like to greet our moderator for today, Mr. M. Tohawi Elziat Purnama, DRH MSI, and also our committees and participants and all parties who support this event. All right, everyone, without any further ado, let's start our main session for today's event. So I'd like to ask Mr. Tohawi, our moderator for today, to lead the discussion session. Mr. Tohawi, time is yours.
Okay, thank you, Dr. Debbie, for your first guidance. Hello, good morning, everyone. I hope you are healthy and stay safe, and also in every condition you keep safe and endurance during this pandemic COVID-19. Okay, this Sunday session I will make you enjoy this session. I am Tohawi, and now I'm serving you as a moderator in this session. During this webinar session, we have invited three speakers. The first is Dr. Chutirat Torsahakul, and the second speaker is Dr. Watchareewan Rodprasert, and the third speaker is my seniors in my division, Dr. Suryo Kuncorojakti. And then we have approximately 15 minutes in every session. Then we will join in the next session is Q&A session. So for all participants, please wait and please join with your device and make it well in your connection until the end session. Okay, now the first agenda, we move to the first agenda. Our speakers is Dr. Chutirat Torsahakul. Let me share Dr. Chutirat CV with Dr. Chutirat Torsahakul. Now she is in veterinary clinician at Chulalongkorn University Small Animal and Teaching Hospitals. In her academic career, in 2011, she's finished the Doctor of Veterinary Medicine in Faculty of Veterinary Science, Chulalongkorn University. Thailand, and in 2021, she's finished a Ph.D. program in Veterinary Bioscience, Faculty of Veterinary Medicine, Chulalongkorn University, Thailand. And also she's experience is ophthalmologist, in satu veterinary clinic and Bangkok Heart Veterinary Hospital. And in 2011, she served in internal medicine unit and emergency unit and veterinary clinician at Chulalongkorn University Small Animal Teaching Hospitals. And we know that Dr. Chutirat Torsahakul also joined in research group with Dr. Suryo, Dr. Rodprasert, and Dr. Chen Ho. She's interest in tissue engineering, stem cell biology, and translation, system biology, and bioinformatics. And also now she is collaborate with Veterinary Stem Cell and Bioengineered Innovation Center in Chulalongkorn University. And it's the awesome CV from Dr. Chutirat. Now Dr. Chutirat will present about application stem cell in Dr. Chutirat will present about the stem cell in veterinary ophthalmology, the translational bioengineered stem cell based corneal seed and stromal scaffold. So it will be an update of the stem cell application in the ophthalmology's overview, and also for the clinician in ophthalmologist. Okay, Dr. Chutirat, are you with us now?
Yes. Can you hear me well?
Yes, clearly.
Can you see my screen?
Yep.
Okay, thank you so much. Okay, let me,
Okay.
I will start now. Good morning, everyone. Selamat pagi. And first of all, I would like to thank the University and Suryo for inviting me to be the speaker today. And my name is Chutirat Torsahakul, Ph.D. student in Veterinary Bioscience. And it is my honor and pleasure to speak in the topic of stem cell in veterinary ophthalmology, translational bioengineered stem cell-based corneal sheet and stromal scaffold. And first of all, I would like to introduce our warm lab room. This is B.Sc room in the Faculty of Veterinary Science, Chulalongkorn University. And this is all of the content I want to present today. The first is the anatomy of the eyes. The second is up-to-date ocular stem cell use. And the third is the stem cell in veterinary ophthalmology. And the last one is state-of-the-art canine corneal bioengineering. Start with the first one, anatomy of the eye. I will show everyone familiar with the anatomy of the eye. Briefly, from outside to inside, the tough outer layer called the sclera, and the sclera covered by the thin layer called conjunctiva. And the anterior part of the sclera is the clear transparent tissue called cornea. And the next layer is the colloid, is the vasculature layer. And the anterior part of the colloid is the eyelid. It is a pigmented circular ring to adjust the amount of the light into the lens. The lens sits behind the eyelid to focus the light onto the retina. And focus on this area. This area is very important because it's the area of ciliary body to secrete the aqueous humor flow from the posterior chamber onto the anterior chamber and flow out at the trabecular meshwork. And sorry, I cannot move. Okay, and this is the anatomy of the cornea. Anatomy of the cornea composed of 5 layers and 3 cellular layers, including epithelium cell. Epithelium cell is the outermost layer of the cornea, and stroma. Stroma composed of the keratocytes, and the endothelium. Endothelium is the monolayer innermost of the cornea. And this area is very important. This is called rimbus. The rimbus is a transitional area between the white opaque of the conjunctiva and clear cornea. And this is up to date ocular stem cell use. First of all, I would like to explain something more about the stem cell. The stem cell can divide into three types, depending on the relative potency: 30%, pluripotent stem cell, polypotent stem cell, and the multipotent stem cell. 30% stem cell is the most versatile stem cell. It's right after fertilization. And the polypotent stem cell is the cells from the blastocyst. It's not as versatile as the 30% stem cell. And the last one is multipotent stem cell. It's limited in what they become. So the ocular stem cell is in the type of the multipotent stem cell. And I will explain about the ocular stem cell depend on the anatomy of the eye. The first is the cornea. The ocular stem cell in the cornea, including the limbal epithelium stem cell and canine corneal stoma stem cell. The limbal epithelium stem cell is the stem cell at the transitional area and the basal layer of the epithelium. And the corneal stem cell, stroma stem cell, is under the limbal epithelium stem cell. So the limbal epithelium stem cell have been used for treatment limbal stem cell deficiency in humans. In this study, they transplant the limbal epithelium stem cell, and 6 months later, the cornea become clearer. And for the corneal stoma stem cell, it's still under study for treatment the corneal scar. This is the eye of animal model. After create the wound, the group with the cell of the corneal stoma stem cell have less scar formation. And about the conjunctival stem cell, the conjunctival stem cell believed to be in the conjunctiva phonic and can differentiate into the goblet cell and epithelium cell. And the conjunctival stem cell have been used for treatment the limbal stem cell deficiency as well. In this study, they compare between three types, after create wound and transplant with the conjunctival stem cell, and transplant with the epithelium stem cell, and the last one, transplant with the amniotic membrane. We can see it in the picture. In the group of the conjunctival epithelium transplantation and corneal epithelium transplantation have better wound healing than the group of the amniotic membrane transplantation. And about the stem cell of the eyelid and ciliary body. Stem cell of the iris and ciliary aim to use for treatment the retinal disease because both cells can differentiate into the retinal regenerative, and there are less study about that. And the cell at the trabecular meshwork. Trabecular meshwork is the area between the cornea and iris. And this is very important because this is helpful for the glaucoma disease. For the trabecular network, we focus on the homing ability of this stem cell. In this study, they tag the cell with the green fluorescent color, and after that, inject the cell into the anterior chamber and follow what they go. At 1 week, 4 weeks, and 4 months, we can observe in this picture that trabecular meshwork stem cell can stay inside the trabecular meshwork area until 4 months. And this is the stem cell of the lens. The stem cell of the lens believed to be in the lens capsule. That is very less study about that they believe to be that this is important for galactogenesis and other lens abnormality. And about the stem cell at the retina, including the retinal pigment epithelium. Stem cell of the retina have already used in clinical application. In the study in 2004, they transplanted the sheath of the fetal retina into the patient with the retinitis pigmentosa. And 1 year after transplantation, the visual acuity become better and better. And this is the summary of stem cell use in clinical application. They already used in conjunctiva, retina, and retina pigment epithelium, and limbus. And another part is still in the animal model phase. The next topic is the stem cell in veterinary ophthalmology. The stem cell in veterinary ophthalmology is not much study about that, but the study about the dry eye syndrome have a lot of the study that's already used. The dry eye syndrome is a disease of immune-mediated syndrome, and they have found this disease to many dogs. And this is a study in dogs. They also use the bone marrow mesenchymal stem cell and adipose mesenchymal stem cell. And the application of transplantation, including the topical eye drop or injection into the lacrimal gland. This is the study of Protocol et al. 2014. This is a control group before treatment. And after that, treatment with the adipose tissue mesenchymal stem cell and follow at day 28 and 12 months after that. We can observe that the clinical sign is better, including the less redness, less inflammation, and the less ocular discharge. And for the tumor test, it have higher. And another disease is eosinophilic keratitis. This disease is all about the immune-mediated in the cat cornea too. In this study, they use the mesenchymal stem cell as well and inject into the subconjunctival. And then the clinical sign follow at day 0, 15, 1 month, 3 months, and 11 months. And the clinical sign improve day by day. And in this case, this is a case of canine corneal ulcer. Both groups create the wound. And after that, inject the bone marrow mesenchymal stem cell into the subconjunctiva and follow the clinical sign at day 1, day 3, day 5, day 7 until day 24. And in this study, it conclude that the clinical sign is not much different between both groups because the day 24, they also have the corneal scar. It's not much different between both groups. So what do you think about the corneal ulcer like this? This is a staphyloma or corneal perforation, and in this case, it's very deep corneal ulcer. It is really difficult to treat medically, right? So I will suggest the corneal graft. The corneal graft has been used in veterinary ophthalmology, including the conjunctival pedicle graft, urinary bladder submucosa, and canine amniotic membrane with good result. However, some disadvantages of graft have been found. For example, limited tissue shelf life, specific storage condition, and graft rejection, a limited number of the tissue owner, and sometimes we found the contamination. So in my study, aim to generate the alternative biosynthetic corneal substitute. Okay, let's move to the topic number 4, state-of-the-art canine corneal bioengineering. The canine corneal bioengineering composed of the parts of the chemical and physical factor, and the last one is the biomaterial scaffold. I will focus on the parts of the cell. Some parts to present corneal tissue engineering are synthesized from the monolayer of the epithelium cell, stratified layer of the epithelium cell, stratified layer of the epithelium cell and the corneal stroma, and the last one is stratified corneal epithelium cell, stroma, and corneal endothelium. I will focus on this. Limba stem cell is the transitional area between white, opaque of the conjunctiva and clear cornea. This area is the area of limba epithelium stem cell. Ring-barred epithelium stem cells have two main functions. The first is to prevent the conjunctiva migrate into the cornea. In case of ring-barred epithelium stem cell deficiency, the conjunctiva can migrate into the cornea, resulting in corneal opacity. And the second function is to maintain epithelial homeostasis. And the next cell is the corneal stromal stem cell. Corneal stromal stem cell is under the corneal epithelium stem cell. And in 2020, Kavanagh et al. Discovered the corneal stromal stem cell in human in the same position like Kavanagh et al. Discovered the corneal stromal stem cell in canine in the same area as in human by using the CD90 marker. This is a marker of mesenchymal stem cell. And the next part is the part of material scaffold. In my study, I will use seals as the material scaffold because they have a lot of advantage. For example, biocompatibility, processability, and non-immunogenic response, controllable degradation rate, and mechanical property, and can process cuneiform, and can control material property and extra degradation rate. And also gelatin, because they have a lot of advantages. For example, low cost, biodegradability, biocompatibility, and low antigenicity. Then no harmful byproduct after processes. And they also provide the RGD sequence that is important for cell adhesion and have very high number of accessible functional groups for modification. And this is a schematic of my work. Firstly, I isolate the cell from the cadaveric cornea to get the both type of cell, corneal epithelium stem cell and canine corneal stromal stem cell. And after that, the cell will sit on the seal fibrin and gelatin film. And after that, certified layer have been promoted by airlifting. And for the canine corneal stromal stem cell, the cell will sit on the sponge-like scaffold. And after the cell adhere to their own scaffold, I apply with the tissue glue on the sponge-like scaffold and gently move the epithelium cell onto the sponge-like scaffold and analyze at day 14 and day 28. For the canine ring-barred epithelium stem cell isolation in my study, I will use a collagen type 1, incubate at 0.5 milligram per ml for 14 hours, 37 degrees Celsius, and scrape at the epithelium site to get the epithelium stem cell. And the cell will sit onto the feeder cell. I will use GTTJ2 fibroblast as a feeder cell. And after isolate the epithelium cell, the left tissue will cut into the small pieces and scrape with the cell scraper and filter through 70 micron cell strainer and seed into the 60 millimeter culture plate. And to preparation of the silfabrin and gelatin film, 5% and 5% of silfabrin and gelatin will combine together in the concentration of 60% of silfabrin and 30% of silfabrin and 70% of gelatin. And after that, blend together at the room temperature for 10 minutes and pour onto the polystyrene tape at 2 ml. And after that, punch into the circular ring. And I will use auto annealing. Water annealing can promote the beta-beta sheet of the seal. And before using, I will use the gas plasma for sterilization. And for the silfabrin and gelatin scaffold in the same concentration, pour into the polystyrene tape. And after that, I will use a fisting dye to create the pore site inside the scaffold. And this hydrothermal technique at 140 degrees Celsius for 72 hours be used for promote the cross-linking at the gelatin. And punch biopsy to be the circular shape. And before using a plasma for sterilization. And about the characterization of the cells, on film and cells on the sponge scaffold. This part will fix with 2.5 glutaraldehyde and characterization by using the SEM. And for the cell viability assay and distribution, corneal epithelium stem cell on film and canine corneal scaffold on the sponge will incubate with casein AM and potassium iodide at 20 minutes. And after that, analyze by fluorescent microscope at day 1, 3, 7, 14, and 28. And cell on film and cell on the sponge like scaffold will incubate at the proteinase K in proteinase K buffer and 20 microliters per sample of papain to analyze the cell proliferation. And after that, I will use the cubic fluorimeter to analyze the number of the DNA. And this is my result. The picture A is the morphology of the canine limbo epithelium stem cell. The morphology looks cobblestone-like cell sheet. The cell formed the colony 3 days after isolation. And the cell surrounding the colony is the feeder cell. In the picture B is the morphology of the canine corneal stroma stem cell. The cell can adhere to the page 2 hours after seeding and reach 60 to 70% confluent within 7 days. And the cell form the fibroblast-like cell. And for the cell isolation, previously, they have a lot of the study used this space for the cell isolation. Because of this space can digest the fibronegative and collagen type 4. This is a component of the basement layer. And nowadays, they have a lot of study use the collagen type 1 because they can get more basal epithelial progenitor cell and close proximity mesenchymal cell and can maintain the basement membrane matrix. And this is the cell characterization after isolation. This part is a part of canine limbo epithelium stem cell, and this part is part of canine corneal stroma stem cell. The gene expression express pluripotent stem cell marker, proliferation marker, and adult stem cell marker, and differentiation marker. And for the canine corneal stroma stem cell also present the myofibroblast marker. So that can be summarized as the cell at the first time is heterogeneous population. And a little bit more information about the P63 and PAC6. P63 have been used to be the marker of the limbo epithelium stem cell since 2005. And they found that just only in the delta and P63 isoform is important for the limbo epithelium stem cell. And in the canine, in 2015, we found that the P63 is also the marker of the canine corneal limbo epithelium stem cell by using the P60 staining only in the limbo layer, but less staining in the central area. And about the PAC6, PAC6 has been used to be the marker of the canine corneal stroma stem cell since 2005. And in terms of the canine corneal cell, the PAC6 also used to be the marker of the canine corneal stroma stem cell at 2020. So I will use the P63 and PAC6 as a marker to characterize the cell. After that, the cell in the process T were staining with the immunofluorescent staining of P50 and PAC6. We can observe in the picture, they have the strong staining of P63 for the canine limbo epithelium stem cell and strong staining of PAC6 at the canine corneal stroma stem cells. And this is the morphology of the film and sponge. Picture A and picture B is the dry form and wet form of the silfibrin and gelatin film. We can observe that the wet form of silfibrin and gelatin look more transparent because of water absorption. And the thickness of the film is 40 micron. construct by 2 ml of the silfaparin and gelatin solution onto the polystyrene tray 5 × 5 centimeter. And the picture C is the picture of the SEM analysis. We can observe in this picture, the surface of the film looks so smooth. Picture D and E is the dry form and wet form of the sponge-like scaffold. In the dry form, the sponge-like scaffold looks very white opaque, and the white opaque is fading after water equilibrium. And picture F is the FEM analysis for the first phase of the sponge-like scaffold. We can observe a lot of holes inside that's constructed by fishing dye technique. And the pore size average is 130.21 plus minus 37.12 micron. This is compatible to this study. This study confirmed that the 95.9 to 150.5 micron is promote the cell adhesion. And the next part is a part of the water content of the silk film and sponge-like scaffold. In the part of the film, the water content is up to 90% and gradually decreased by time. And SFT scaffold is up to 85% on time point. So for the gradually by time, we can explain by the percentage of the gelatin in the component of the film. They are 70% of the gelatin that are non-cross-linked, so they have some part of the saturated gelatin dissolved in the water content. And for the next study, we suggest to use the higher temperature for cross-linking the SFG film. In this study, if we turn the temperature to 95 degrees Celsius, the silk film can turn the beta better cheap and stronger. And about the degradation, the SFG film and SFG scaffold. From the graph, the SFG scaffold have the faster degradation than SFG film. This is possible caused by the porosity of the SFG sponge-like scaffold. And the next part is the tensile test. I will analyze the tensile test of film and sponge-like scaffold by elastic modulus, ultimate tensile strength, and elongation at break. The elastic modulus of my scaffold is compatible to the natural human cornea, 0.3 to 7 megapascal. And we can observe in this number, the elastic modulus, ultimate tensile strength, and elongation at break at the film is higher than the sponge-like scaffold. This is because of the porous as well. In this study said that the elastic modulus, ultimate tensile, and elongation at break decrease when increase of porosity. And the next part, this is a SEM analysis of the cell on film and the cell into the sponge-like scaffold. Corneal inbound epithelial stem cell on the film can promote the stratified layer about 2 to 3 layers. And the cell in the basal layer looks smaller than the cell in the upper layer. And for the corneal stromal scaffold, the cell can penetrate into the pore side and can secrete the extracellular matrix. For the cell adhesion, it is influenced by the RGD sequence. Because in my study, I used the gelatin as the scaffold. So gelatin provides a lot of RGD sequence. And in this study, the result of this study, the cell on the RGD scaffold and the cell on the without the RGD scaffold. We can observe in this picture, the cell sit on the RGD scaffold. The cell can adhere better than the cell sit on the scaffold without RGD. And this is the live test staining. After I see the cell on the film and the cell on the scaffold, and I analyze the live test staining at day 1, day 3, day 5, 7, 14, and 28. The green color is the color of cell alive, and the red color is the color of dead cell. We can observe in this picture, the cell can survive up to 28 days and just a few cells dead. And this is the proliferation assay. The proliferation assay of the cell on film have the high proliferation between day 3 to day 5, and the cell on the scaffold have the proliferation phase between day 7 and day 14 and day 28. This is because of the substrate. In this study, they try to use the corneal epithelium stem cell on different substrates. And in the collagen type 1, the cell can have the proliferation phase after 3 days, and after that remain pardon. Is compatible to this study. So we can compile that. The silfabrin and gelatin have the capacity to promote the proliferation the same as the collagen type 1. And for the cell proliferation in this, they have the longer cell proliferation phase at day 7. It may be caused by the xylem free. And for the gene expression, corneal epithelium stem cell can divide into 3 groups of gene expression. The first group is a group of control. It's a epithelium stem cell sit on the culture pad. And the 14th day is the cell sit on the film at the 14th day. And 28th day is cell sit on the film at 28th day. We can observe in the graph the gene upregulation at 14th day and 28th day better than control group. This is because of the substrate stiffness. In this study, they use the corneal epithelium stem cell and try to find the upregulation of the stiffness gene after sit on the stiffness that the cell like. And this is a Ki67, which is the proliferation marker. They have the upregulation at day 14 and downregulation at day 28. The downregulation at day 28 can be explained by the contact inhibition. And about the keratin 3 and keratin 12, which is the differentiation marker, the upregulation at day 14 and day 28. Because of the airlifting interface. The airlifting interface can promote the cell differentiation, including the cytokeratin expression. And about the gene expression of cell on the SFT scaffold. They can present the upregulation of the stiffness marker that can explain by this study. Is the mechanism responsibility and differentiation potential of the cell on the electrosponge scaffold. And the downregulation of CD90, downregulation of ACTA2, which is the myofibroblast marker, and upregulation of NTFR and nestin, and the upregulation of the keratocyte differentiated cell marker. So the downregulation of ACTA2, that means the keratocyte is not differentiated into the myofibroblast. So this is a good result because if the keratocyte differentiate into the myofibroblast can create the stoma fibrosis. And for the upregulation of the keratocan and lumican, which is the extracellular matrix, which is important for the collagen fibril alignment, that can create the transparent cornea. And for the SFT film on the sponge-stoma scaffold. In this picture is the morphology after I apply the fibrin glue and put the corneal epithelium on the stoma scaffold. It looks a little bit opaque. And this is the SEM analyzation. SFT film can rely on the corneal stromal scaffold. The cell in the sponge-like scaffold can penetrate inside, and the cell epithelium on film can align on the SFT film. And this is the result of the immunofluorescence staining after I see the cell on their own scaffold at 14 days and 28 days respectively. For the H&E staining, this is the staining of the lymphoepithelium stem cell on SFT film and fluorescent staining. The cells can present the P63, which is the marker of lymphoepithelium stem cell. And this is the FFT staining of the cell on film at day 28. The morphology of the cell at day 28 is bigger than day 14. The bigger morphology can explain about the differentiation cell. So the P63 staining of day 14 is much stronger than day 28. And the size of the cell at day 28 is bigger than day 14. So it's because of the air-liquid interface. After air-liquid interface, the cell promotes the epithelial proliferation and differentiation and stratification by shift the oxidative metabolism, the growth phase to differentiation phase and polarization effect. And this is a H&E staining and immunofluorescence of the lubricant and aldehyde dehydrogenase 3A1 at day 14 and day 28 of the cell on the sponge-like scaffold. We can observe in H&E staining, the cell can penetrate inside the pore of the sponge-like scaffold at both timelines. And for the fluorescent staining of the lubricant at day 28 and day 14, day 28, the lubricant have the highest expression than day 14. And for the aldehyde dehydrogenase, the expression of the aldehyde dehydrogenase is quite similar. And this is the immunofluorescence staining and H&E staining of the biofabricated corneal current. This is a cell on film coupled with the cell on the sponge-like scaffold at day 14 and day 28. In this picture, we can observe the P60 staining, especially in the basal area at both timelines. The basal area, this is the area of lymphoepithelium stem cell. And for the lubricant in both timelines, the lubricant at day 28 have the higher expression than the lubricant at day 14. And for the aldehyde dehydrogenase, the aldehyde dehydrogenase at day 28 and day 14 is difficult to compare. And about the collagen production, I will marginate the yellow color. This is the area of the scaffold. Collagen can be produced at day 14 and day 28, but a little bit more. The cells that lie along the scaffold can produce the collagen alignment in unilateral. On the other hand, the cell is not aligned on the scaffold, which produce the collagen fiber in multiple alignment. The factor of the collagen production. Wu et al. Study about the factor of the collagen production related with the RGD sequence. The human corneal stromal stem cells sit on the substrate with RGD and without the RGD. The substrate with RGD sequence can secrete more collagen fiber than the substrate without the RGD. And another factor is FGF2 and PGF-beta3. Wu et al. At 2013 study about two factors. In the condition A is the condition of the cell with FGF2. The collagen fiber can produce in unilateral direction. And for the picture B, in the condition of TGF-beta3, the collagen fiber can produce in orthogonal direction. And in the condition C is combined between two factors. The cells can secrete the collagen in orthogonal and multiple layers. So a little bit about the creation yesterday, and have somebody ask about the endothelium keratoplasty, which one is the gold standard, right? I am not sure, because in veterinary ophthalmology, we never done endothelium keratoplasty yet, but this is the human ophthalmology procedure. We do dissect and demake. And which one is better is quite difficult to say, because I never done something like this before. And something more about the dissect is the graft is up to 20% of the corneal thickness. It means like the graft is thicker than demake. The graft is around 2 millimeters. They use just only the endothelium transplantation. So they said that the success rate of the demake is higher than dissect, but they usually do dissect because it's easier, because the graft is thicker and it's easier to manipulate. And about the endothelium stem cell transplantation, they have a lot of the study about that. And by doing the graft transplantation, by seeding the cell in the collagen sheet, or maybe seeding the cell in the gelatin sheet, or maybe seeding the cell in the synthetic material and transplantation. And they also have another application by injection the cell into the anterior chamber. This study is studied in the monkey and in the rabbit eyes. And the only thing that I know is that I know nothing. Thank you a lot, B.Sc Big, and B.Sc Big member, Secretary Dr. Chen Pop Sawangme, who is my advisor. And thank you everyone for your attention.
Okay, thank you, Dr. Chutirat Torsahakul. Wow, an excellent presentation from Dr. Chutirat Torsahakul. Thank you. In my opinion, this application can answer the challenge of ocular disease in the future. So maybe the next or further study need to be improved to share about information in stem cell application in ocular disease. Okay, thank you, Dr. Chutirat Torsahakul. And now I hope you wait until the Q&A session. Then join with Dr. Rodprasert and Dr. Kuncorojakti for a joint discussion in the final session. Okay, let's move to the next agenda. The second speakers is Dr. Watchareewan Rodprasert, and she's present about the bioengineered regenerative therapy for diabetes mellitus, establishment on canine mesenchymal stem cell derived insulin producing cells. Now I'm going to share Dr. Rodprasert's CV. Okay, please wait. Okay, Dr. Watchareewan Rodprasert, Bachelor of Science, Doctor of Philosophy. Now she is in the affiliation from interdisciplinary program of pharmacology, Graduate School, Chulalongkorn University, Thailand. In academic career, she's finished the Bachelor of Science in School of Health Science Mai Fah Luang University, Chiang Rai, Thailand. And in 2021, she is in Ph.D. program in interdisciplinary pharmacology program, graduate Chulalongkorn University, Thailand. We know many experience from Dr. Watchareewan. Yeah, the latest experience you can see in your screen. Yeah, in the latest experience in 2018. She was joined training in Laboratory of Embryology, Faculty of Veterinary Medicine, University of Teramo, Italy, and the research area in stem cell biology and therapy, regenerative treatment for diabetes mellitus, and Dr. Rodprasert published 5 papers, is Scopus indexed. And also she have many experience, yeah, in stem cell biology because she joined in research study group in Chulalongkorn University, focus in stem cell biology. Okay, Dr. Rodprasert.
Yes.
Yes. Can you hear my voice clearly?
Yeah, very clear.
Okay, thank you. Okay, I remind for all participants, if you have any inquiries, please write your question in the chat box, or you can choose the raise hand symbol, then you can ask to the speakers directly. Okay, please welcome Dr. Rodprasert. Time is yours. Thank you.
So thank you so much for the moderator, and so sorry for about my name, that it's very hard to pronounce it. So okay. Yeah. So first of all, I would like to say thank you to Suryo and the University of the Airlangga for inviting me, and this is the first time for me for being is the speaker in the webinar. So if I so excited or something like that, so never mind me. So first of all, let me introduce again. My name is Watchareewan Rodprasert, and my friends also call me Ruktan. So for my bachelor degree, I'm graduate from Mesenchymal University in the Bachelor of Science about the applied Thai traditional medicine. So, and then in last 5 or 6 years ago, I decided to apply in the interdisciplinary program in pharmacology at Chulalongkorn University. At first, I studied the research in the cancer, especially in the human laboratory at the pharmacology department of the medicine school of Chulalongkorn. And then I moved into our lab now, the Veterinary Stem Cell and Bioengineering Innovative Center, or WISPIC. And during my PhD study, I have a great opportunity to join the fellowship program with the Marie Rice program of European, and have a chance to go to have the short work at the embryology laboratory of the University of Teramo, Italy. And then in this year, I just graduated in the Doctor of Philosophy in Chulalongkorn. And now I'm working at our startup company called Bioengineered, and soon to be the postdoc in our laboratory too. So since according to my research field and the research of interest about the stem cell biology and the therapy with the regenerative treatment, especially the diabetes, is leading to the topic that we're gonna speak today about the bioengineering regenerative therapy for diabetes mellitus, about the establishment of the canine mesenchymal stem cell derived insulin producing cells, which this research we had published already in the scientific report of this year. So first of all, let's talk about the diabetes mellitus. The diabetes mellitus is a disease that's caused by the metabolism disorder with the common symptom that about the hyperglycemia or hyperglycemia that we can see the high blood glucose level. And this disease were divided into two main types. By type 1 is caused by the beta cell destruction from the host immunity. And this type is normally like the inherited disease, and it can found in the young patient, and they have to receive the treatment in the young age. For the second one, is type 2, is caused by the insulin resistance and other secretion defect. Mostly this type will found in the older patient, which normally caused by the degradation of the body. Cause the degradation of the beta cells, which is the important cell to produce the insulin, the essential hormone, which control the blood glucose level, and also maybe caused by the degradation of the insulin receptor at the target organ. So this disease it's kind of like is a disease that also like the most concern in every public health in each country in our world, because the rising of the number in every year, and also in the the disease that unable to treat, which also affect in human and in the companion animal, especially the dog. And this disease in human, they will found both types of diabetes, which is type 1 and type 2. Also same as in the dog, that they able to find in both type of it, but the most type that were found is the type 1 diabetes, which have the same cause of the disease, same as in the human. So let's talk about like the general thing, like how our body regulate the blood glucose level. When we intake the food into our body, they're gonna be like digested into the glucose. And then the glucose will be traveling around our body via the blood capillary and leading the blood glucose level to upregulate. Then when the glucose is traveling to the pancreas and meeting with the beta cell, they will trigger the beta cell to secrete the insulin, the essential hormone, to regulate blood glucose level. After that, the insulin will also traveling via the blood circulation and then bind with the insulin receptor on the target cells, which will cause like the signaling cascade in that cell. And then that cell will influx the glucose into their body, which leading to the blood glucose level becomes decreasing. However, in the DM patient, especially for the Taiwan, that they didn't have the beta cell. So it means that they cannot produce enough insulin to regulate the blood glucose. So, and the glucose cannot enter to the target cell, it leading to the blood glucose level still increasing. And nowadays for the treatment, in both human and dog, in Taiwan, they still need to receive the insulin injection with the daily modulation, which can cause two main problems. My first, and I said that if this disease is like unable to treatment, or we call like the intractable disease. So especially in the Taiwan, so the patient may need for the lifelong treatment, which can cause the failure in blood glucose control. And they also need the insulin dosage optimization in daily. And another one is about the adverse effect from insulin injection that can cause the hypoglycemia, which also like the another reason for this animal also. So from that problem, it leading to the new study about the regenerative medicine. By we have the expectation to regenerate and also the repair the beta cell of the pancreas for diabetes Taiwan. And nowadays they have like two main interesting methods in this regenerative medicine, which called the eyelid transplantation and the induction of the beta cell, which have two ways to induce. First is the cider leg induction in the animal, and the second one is the in vitro induction. For the eyelid transplantation, we all know the name, in the name of the Edmonton Protocol by the daughter. By this treatment, we require for the require the pancreas from the donor, and then the pancreas will be extract the islet, and the islet will be transplanted into the recipient. And from this treatment, we found that the patient Taiwan diabetes can like control their blood glucose level without the insulin injection for a while. However, this method still has the limitation. First one is the lack of the islet, because it's difficult, because as I say, the diabetes patient is like increasing in every year. So it's like impossible to find enough islet for everyone. And moreover, this one is a allogenic transplantation. It means that the patient needs to take like the immunosuppressant drug. Then the patient has to face the side effect of it, which is mainly about like the increase the risk to get infection from any microbial or anything. So for another one about the beta cell induction, with the side-like beta cell induction, this one is like we directly inject the cell to the animal and then put some chemical to trigger that cell to secrete the insulin. So these methods still have the limitation also, because we can see the ectopic expression of the cell in another organ, we able to like develop into the into the tumor or the cancers. So from this limitation, which is become as like the bottleneck in the new trend of diabetic treatment, it become the in vitro beta cell induction become our hope, by we have the idea to use the stem cell to answer to solve the problem of the lack of the number of islets. Then the stem cell will be transduction or induction into the insulin producing beta light cell. By nowadays they have like two ways to inducing it. By the first way we call microenvironmental manipulation, that we use like the macro and microchemical to mimic the environment during the stem cell culture to the environment during the natural pancreatic development. For the second one, we call genetic manipulation, which is like the direct differentiation of the stem cell by the we force the cell to express the specific specific gene in the pancreatic development process. And then after we got the insulin producing cell, this cell will be implanted or transplanted into the diabetic animal. So let's talk about the stem cell. Stem cell is like the progenitor cell for every cell type and the tissue, also the organ in our body. By stem cell, they have like two unique properties. By first one, we call the cell renewal, whether the single cell of it able to replicate themselves with the daughter cell had the same property and also like the morphology as their mother cell. The second one we call the multi differentiation property, that the single cell able to differentiate it into many cell types in our body. And this stem cell we divided into two main types. My type 1 is a polypotent stem cell, and the second one is a multipotent stem cell. The polypotent stem cell or the embryonic stem cell, which is the first like stem cell type that was found, they collecting from the inner cell mass of the embryoblasts. And this type of stem cell have able to give rise to any cell, any tissue and organ in our body. Second, for the multipotent stem cell, or we know as like the daughter progenitor cell, even though they can give rise to any cell type, same as the polypotent stem cell, but they still have like the limitation for differentiate when compared with the multipotent stem cell. So in our laboratory, the stem cell type that we choose is a mesenchymal stem cell, which is the multipotent stem cell that have the cell renewal property and also able to differentiate into any cell in the mesendoderm lineage. For example, like the adipocytes, osteoblasts, or neuron. And this cell type have many study and research to confirm for using in the insulin producing cell production. And about the pancreatic endoderm development process in natural. Normally, it's the pancreas before they become the pancreas or the beta cell. they will start to form the pluripotent stem cell, which they have like 6 steps to going through the insulin producing cell. And our cell, the mesenchymal stem cell, we can say that they are in the mesendoderm step. It's after pluripotent step. And you see they have 3 steps more become the insulin producing cell. And in each stage, they also have like the specific gene to helping the cell in each stage driving to another stage. So let's talk about the way the method to induce the stem cell to be the insulin producing cell. But first, I will talk about the microenvironmental manipulation approach, which is to mimic the environment during the stem cell culture to be same as the natural pancreatic development. From previous study, to gain the insulin producing cell, they also have like many steps to get it. Like if you're starting from the human embryonic stem cell, this is the pluripotent stem cell, you may need 5-step induction for like 5 recipes to get the insulin producing cell. And if you use like a mesenchymal stem cell, you may need just 3 steps to differentiate them. So in our laboratory, the in vitro beta cell induction for diabetic treatment in the animal, we study in this field by Dr. Jacob Swanbeck, that they use by he start using the human mesenchymal stem cell from the dental tissue to like to clarify the remedy or the method to induce the mesenchymal stem cell to be the insulin producing cell. And I say that mesenchymal stem cell is a cell in the mesendoderm state and need more 3 steps to get the insulin producing cell. So the method that we should from the previous study from Chandra and Govind Darasamai, they use like a 3-step induction. Like by the use 3 days for definitive endoderm induction media, and then followed by the 2 days of the pancreatic endoderm or progenitor induction media. And then the last one, until we got the insulin producing cell, they will culture in the pancreatic endocrine or insulin induction media for 5 days. And the result for two type of the mesenchymal stem cell for the dental tissue, we found that after 10-day induction, we can got the insulin producing cell that have the morphology same as the natural eyelid, which is formed like the 3D protein spheroid. And in the last day, when we check the pancreatic marker, they can show that the upregulation in all markers, which relate to the pancreatic development. However, the number of it didn't show that much, just around 50 colony per time, even though we started from the 1 million of the cell. One more thing, for this protocol, we culture the cell in the low attachment surface cell culture dish that not allow the cell to attach to the disc surface, so they can bloom or growing as a 3D spheroid like this. So like I said before, that the number of the colonies is not that much. So he continued to like optimize the protocol, playing with the node signal here. how is the not signaling is important? As you can see that from the progenitor cell, stem cell, they become like the pancreatic progenitor by express the PDX1 here, and then become as the pancreatic endoderm progenitor by express the NGN3 with the cell that have the NGN3 positive, we're going right to the beta cell or the alpha cells. So the HES1 gene is a transcription factor of the not signaling. They play the critical role by inhibit the NGN3. So it means when they like activation, the NGN3 will gone. And it means that the progenitor, the pancreatic progenitor that express the PDX1, we're going to like just the dark cell or the exocrine cell in the pancreas. So it means that if we inhibit this signaling, we may like get more of the beta cell or the alpha cells. So Dr. Genpo used this theory to inhibit the NOx signaling at the first step here and the second step here, and also like the OR step. And the result, he found that when he inhibit at the second step here, we can got like the high number of the colony, around 100 colony per time, with the high expression of the essential gene when compared with the general protocol, which is just 3-step induction. So from this result, as you can see, like the insulin here, there's still row occasion, which is the insulin is like the specific or like the important target that we should check when we producing the insulin producing cell. So from this result, we're going through to another method, which is called genetic manipulation or direct differentiation protocol. When from like previous study, normally they're gonna like use a PDX1 to translate to the cell, for the stem cell to express this cell and then going to the insulin producing cell. And some paper they use like the cocktail, the 3 essential gene in each step. Like the PDX1 is important in the pancreatic endoderm, NGN3 important in the pancreatic endocrine, and MFA or MAFA is like essential gene in the pancreatic beta cell stage. So in our study, like from like that probably in last year, with the same human mesenchymal stem cell, we use the integrative method by using the microenvironmental 3-step induction combined with the genetic manipulation with the PDX1 transduction. And the result, we found that after we transstill the cell with the PDX1 and then continue culture them with the 3-step induction, we found that they can increase the gene, essential gene, especially insulin. Also like give like the number of the cell. However, from this study, We also like establish the protocol with the depth too to get more the number of them. But we found that the number is not that increased that much. And also the gene is not unable to compare when we use just only when we didn't use the depth or the not signaling inhibitor. So from this result, it's leading to our study about the canine mesenchymal stem cell derived insulin producing cell. So in this study, we use two types of the canine mesenchymal stem cell, which collect from the different organs. But the first one we call the canine bone marrow mesenchymal stem cell that we extract from the bone marrow. And the second one is a canine adipose mesenchymal stem cell that collect from adipose tissue. Before we verify on the insulin producing cell process or method, both of cells will check the stem cell property, also the multi-differentiation property, which is like the property of the stem cell. And we found that both cells can show the good stem cell marker and also able to drive into the multilineage cell. Then after that, the mesenchymal stem cell will be driving into the insulin based on these three protocols. But we do like the series testing, we starting from the microenvironmental manipulation approach. And if the insulin cell is not like get like enough number or like didn't show the good phenotype or the functional, we will go through to the second, which is the genetic manipulation approach. And the third one is the integration of the genetic and the microenvironmental manipulation approach. So for the result, we found that both canine mesenchymal stem cell of the bone marrow and adipose able to produce the floating insulin producing cell. However, both two types of mesenchymal stem cell, they have like a different method to induce them to be the IPC or the insulin producing cell. By the bone marrow, we found that the integration protocol of the genetic with the microenvironmental method can got like the good colony and which express the pancreatic related gene and respond to the glucose when we challenging them, like incubating them with the glucose solution to see whether they can produce insulin or not. We found that they can respond to the low concentration of the glucose at 5.5. That equal to around 90 to 100 milligram per deciliter, which is the glucose level range, like the normal glucose level range in the normal person, in the normal people. And moreover, this protocol, they also require the 3D culture. What is the 3D culture? The 3D culture, all I call like the hanging dog protocol, that not the cell, that citizen cell in the system, like that create like the water bowl, and then with the cell, and then the cell will accumulation and form the colony inside that water bowl, and not let the cell to attach to the culture disk. And from this result, we found that one time we only just able to produce the colony or the IPC just only 96 colony per time because the system is the 96 well paired. So it means that if you need a lot of colony that's gonna use for the transplantation, it means that you need more of the plate to produce it. Why the bone marrow is have the critical technique and method? The adipose mesenchymal stem cell we found is easily to produce the IPC than the bone marrow. But we use just the microenvironmental manipulation approach to induce them on the low attachment cell culture dish, the same as the technique that we use in the human mesenchymal stem cell. And we found that only one time we can got colony around 800 colony, which they show the good expression of the related pancreatic marker gene, and also able to respond to the high concentration of the glucose, which at 22 millimolar, which is equal to the glucose in our body around 300. So it's more than 200, which is the threshold to clarify the diabetic patient. However, from this result, we still playing with the not signaling. But we didn't do all cell or all protocol. We're gonna choose only the best high property, the high property and the high potential protocol for producing IPC from the canine mesenchymal stem cell based on 3 criteria. But the first criteria is about the colony, whether they can produce the IPC colony that have mimic to the eyelid, the natural eyelid, and also can produce the number that enough and for the transplantation and in the good size. About the size, we claim that the small to the middle size is the best one, because if the bigger size, it means that it increases the risk of the necrosis of the cell inside the bone too. So the second criteria is about the pancreatic mRNA marker expression. And the last one is about the maturation and functional capability of the insulin producing cells. For the first one about the colony, we found that only 4 protocols that show that we can got the colony. However, for the microenvironmental manipulation of the bone marrow mesenchymal stem cell, actually we use 3 techniques to culture them. For first one is a low attachment dish, culture dish, but we cannot got the colony the floating colony because they are all attached to the dish. So we come to the 3D culture, we have 2 techniques. First one is a hanging dome, and the second one is a metigel-based dome culture that we will form the dome first and then feeding a cell into the metigel dome. And in the end, we found that only the hanging dome culture cell are able to collect the IPC, because from the metigel dome, we found that it's difficult to collect the colony according to the degradation of the gel. When we digest the gel, it also digests the colony too. So another method that can got the colony is an integration method of the bone marrow mesenchymal stem cell that's still able to get just only 96 colony. And the last one is a microenvironmental method induce the canine mesenchymal stem cell into the Ipc using the low attachment cell culture dish. And this found that we can got around 800 colony per time. So only three methods that we're gonna choose to the next step. The next step is about the pancreatic mRNA marker expression. We found that these three protocols, the Ipc from them can express the pancreatic related marker gene. And the interesting thing that the integration method of the bone marrow mesenchymal stem cell, they can give rise or upregulate the insulin gene more than the hanging dog culture of the bone marrow, and also the microenvironment of the adipose mesenchymal stem cell. For the third criteria about the maturation and the functional capability, we found that these three protocols at the basal condition, which is no glucose, they are able to secrete the C-peptide. What is a C-peptide? C-peptide is one of the elements of the pro-insulin. It means that if we see the C-peptide, it means that cell or insulin producing cell able to produce the insulin by themselves. So from the basal condition, we found that the bone marrow with the hanging dog show the highest concentration of the C-peptide among another protocol. However, when we do like the challenging or the silly glucose stimulation, we starting from the low concentration of the glucose and then continued to the highest concentration of the glucose. The hanging dog, we found that the C-peptide level like just has like lower secretion when compared with the low concentration of the glucose. While the integration method of the bone marrow and the microenvironmental of the adipose mesenchymal stem cell, even though they start from the low concentration of the C-peptide secretion, when we like showing or tinker with the glucose concentration, they can upregulate a little bit, like accumulate like the silly in like the dose dependent secretion. However, we are still not see like the significance between each group. So from these three criteria, we're gonna choose the adipose mesenchymal stem cell with the microenvironmental manipulation approach, because it can produce the colony that have the morphology same as the eyelid, and also with a high number colony production per time, even though and also show the upregulation of the pancreatic related marker, even though they didn't see the PDX1, which is like the indicator of the pancreatic progenitor. And also about the functional, whether they can respond to the glucose stimulation. Moreover, the adipose mesenchymal stem cell, when compared with the bone marrow stem cell, they are easier to collect and handle in the laboratory. So for the next step, for the optimization of the Ipc production protocol, we are still playing with the NOx signaling. By we're gonna use DAP as the NOx signaling inhibitor. And we also use the DAP in the same protocol in the human mesenchymal stem cell that inhibit that the first step of the three-step induction and the second step of it. And the result, we found that even though the number of the colony is less than the general protocol without that, But we found that the size of the colony, we found they are most in the modulate and the small size of it, especially when we use the DAP at the second step, that I'm gonna call DAP B. So how about the gene? As before, the DAP B group here show like the good production, the IPC in the small and the modulation size. In the gene expression, we found that when compared with the DAP A, the DAP in the first step, they show like the less expression of the essential gene than the DAP A. However, in the functional property, the C-peptide secretion level, we found that they show the high level of C-peptide in each condition. However, we found that the DAP, the using of the DAP chemical, we can increase the expression of the PTX1, which is the pancreatic proteinator gene. So from this study, we can conclude that from the first study of our laboratory with the human dental pulp tissue, the mesenchymal stem cell for the human dental pulp tissue, we found that the protocol that we showed is able to produce the insulin-producing cell in the human. And we're gonna use this platform for the canine mesenchymal stem cell study. By the canine, in here, we have two candidates. It is a canine bone marrow and the canine adipose mesenchymal stem cell. And we found that these both mesenchymal stem cell type are able to produce the insulin-producing cell. However, in each cell, they require the different protocol, which means that in each cell type, they require the tailor-made protocol for itself. However, the IPC that we got is still non-maturation, that they cannot fully respond to the glucose when we trigger it. However, from this study, we found that the good candidates for the canine mesenchymal stem cell that gonna choose for study more in the method development is a canine adipose mesenchymal stem cell with able to produce the IPC with a lot of number. And also able to like the technique to collect, to handle, and so the technique to induction is also easier when compared with the bone marrow, which we use just only the microenvironmental method and also with the low attachment age. And moreover, the using of the DAP or paying with the not signal, it can like improve about the number of pancreatic progenitor, also the C-peptide secretion. So for about our future plan, I'm gonna separate into two parts, about the cell and about the transplantation platform, or like the cell therapy for the diabetes. For the IPC, we aim that we want the ready-to-use insulin-producing cell for using in the diabetes treatment. But we have two things that we have to study more or develop it. So first, to find a protocol that like get more maturation of the insulin-producing cell. And also if they still not mature, difficult to make them to be mature, maybe we have to find another alternative cell type like the canine induced pluripotent stem cell. With both of these protocols, we are on the process of study. For the second one, for the platform, for like gonna use for the the real treatment with the stem cell based diabetic treatment. They also have two things that we have to study more. The first one is a ready-to-use insulin producing cell for the transplantation, which maybe like have to control the invasion or migration of the cell that we gonna transplantation, also to prevent the immunity from our body too. So the second one is about to study and find the effective transplantation platform also in the animal protocol and also in the target animal that we gonna like study or treatment in the future. So that is all from my presentation, and thank you again for giving me the great opportunity to being as the speaker in this webinar. Thank you so much.
Okay, thank you, Dr. Rodprasert, for your excellent presentation. Yes, thank you. We know that diabetes mellitus is a disease with a high prevalence worldwide. Yeah, we are optimistic that this study will be the answer to that challenge. Yes. Okay, thank you. I hope you wait until the Q&A session. Yes. After this, the last session, the last speakers from Dr. Suryo, you can join us to discuss about the question from participants. Okay, let's move to the next agenda, the last session, the last agenda from my senior in division of veterinary anatomy. The third speaker is Dr. Suryo Kuncorojakti, and present about the prototype transplantation platform study on alginate-based encapsulation of human dental pulp stem cell derived insulin producing cells. Let me share you Dr. Suryo CV. Okay. Dr. Suryo now is Associate Professor in Veterinary Histology, Faculty of Veterinary Medicine, Universitas Airlangga, and his academic career in 2004. He finished the Doctor of Veterinary Medicine from Faculty of Veterinary Medicine, Universitas Airlangga, and then in 2008, finished the Master of Veterinary Science in Vaccinology and Immunotherapeutic, Faculty of Veterinary Medicine, Universitas Airlangga, and followed in 2017, start in Ph.D. program in Veterinary Science and Technology, Faculty of Veterinary Science, Chulalongkorn University, Bangkok, Thailand. And he write 2 book chapter in histology, part 1 and part 2 in Bahasa and also in English. And his research area in stem cell biology and material for translational in human and veterinary practices, and also translational vaccinology. Dr. Suryo now collaborate in develop Merah Putih vaccine, and now will be released in the next year for vaccine for COVID-19. And Dr. Suryo published many papers in international and national indexes, so it's very awesome CV from Dr. Suryo. Now I will contact Dr. Suryo. Dr. Suryo.
Yes, I'm here.
Yes, okay.
Can you hear my voice?
Yes, clearly, Dr. Suryo. Wait,
Okay.
I'm going to spotlight your screen.
Okay, let me try to share my
Okay.
PowerPoint.
Yep.
Can you see my PowerPoint now?
Okay. Yes. Yes, clearly.
Okay.
Appreciate
Okay.
with thanks. Okay. Please,
Okay, thank you
Dr. Suryo.
for
Okay, time is yours.
Thank you for Dr. Tohavi. Actually, I just supporting staff in the vaccine development of Merah Putih vaccines right now. I'm not a part of I'm not a big part of that groups. I just do some small work on that. Okay. Good morning, everyone, and thank you to the committee for the opportunity. In these sessions, I will try to share my tiny work during my PhD at the Veterinary Stem Cells and Bioengineering Innovation Center, Faculty of Veterinary Science, Chulalongkorn University. And today's topics will be related with the prototype transplantation platforms, a study on the Eyelid-based encapsulation of human dental pulp stem cell derived insulin producing cells. Maybe Dr. Watchareewan already explained a lot about the induction protocols. And in this occasion, why I have to use human dental pulp stem cell instead of canine stem cell is because at that time the protocol the induction protocol for canine were still under developing by Dr. Watchareewan. So that's why I use human mesenchymal stem cell as a models. But I will highlight one of strategy for transplantation by using alginate-based encapsulation. Okay, and the outline of my presentations will be the introductions, the concepts, the research flow, the research results, and the conclusions. Let me start with the introductions. I think Dr. Watchareewan already mentioned about the diabetes mellitus. As an intractable disease, diabetes mellitus is a chronic metabolic disease that caused by the incapability of the pancreas to secrete the insulin, or the inability the body to use the insulins. And the most common clinical signs of this disease is hyperglycemia that can lead to several complications in several organs such as a kidney, an eye, brains, cardiovascular system, and so on. Similar as a human medicine, in veterinary field, the diabetes mellitus also can be classified as type 1 and type 2 diabetes mellitus. Type 1 diabetes mellitus is insulin dependent, associated with the autoimmune disorder, and that cause pancreatic islet defects and less or absence insulin production, while the type 2 diabetes mellitus is a non-insulin dependent and caused by ineffectiveness of pancreatic insulin secretion and or insulin usage by the body. As we can see in this slide, in human medicines, the estimated global prevalence of diabetes mellitus reported by Cho et al. In 2018, people with diabetes mellitus will dramatically increase from 151 million in 2000 will jump into 451 million in 2017. And it will be projected will be increased almost 700 million people will get diabetes mellitus in 2045. Though not many studies reported the prevalence of diabetes mellitus in veterinary field, a study in the United Kingdom in 2040 reported that the prevalence diabetes mellitus in dog was 0.34%, while in cats was 0.58%. Regarding the development therapy of type 1 diabetes mellitus, let we see a starting forward in the past around 180s. There was no specific therapy of type 1 diabetes mellitus. The management of this disease was only based on the diet or calorie restrictions. Then jump into 2020 and 1922, revolutionized was happened when Banting and his colleagues invent the insulin in these years, and then come out jump into 1980, the first auto transplantation pancreatic islet was performed, and also the pancreatic islet encapsulation was performed. And finally, in 2000, the Edmonton Protocol was established, as Dr. Watchareewan mentioned before. In 2000, Shapiro and colleagues established this protocol called as Edmonton Protocols. In this protocol, they use purified pancreatic islet isolation from cadaveric donors, and then that purified islets will be transplanted into the patient. And to avoid rejections, they still use immunosuppressant agent. So that's why this protocol still have any limitations. The first limitation is the limited number of cadaveric pancreas donor, still hard to be achieved. Why? Because for doing the transplantation in one patient, they need 2 until 4 islet donors. Then another obstacle is the long-term use of immunosuppression agents also become the limitations, since it might cause the side effects. And currently, the regenerative medicine can be proposed to overcome the obstacle. Several studies reported that the utilization of adult stem cells have many advantages, which were have no ability to generate a tumor, ability to modulate the immune system. That's why it's good potency for allo transplantations, easy to manipulate, and no ethical concerns. And how about the MSC? The MSC is a non-hematopoietic stem cells. Is it a multipotent and have a self-renewal capability and have multilineage differentiations ability. And in this study, I'll use dental pulp stem cell in isolate from human. Because several study already established the induction protocol from the human dental pulp stem cells, as well as in our laboratory, the optimized protocol also was established. So that's why I use a human dental pulp stem cell as a model for transplantation platform. I think Dr. Chan Pop and also Dr. Watchareewan already mentioned about this slide before. In this slide, I just want to summarize the differentiation of stem cells into the Ipc, starting from pluripotent or multipotent stem cell that can be driven into the mesendoderms, and then definitive endoderm, pancreatic endocrine, and finally the mature beta cell. And each stage, many transcription factors uninvolved, such as in the mesendoderm stage, the mix 1 and brachyury are involved, and finally in the mature beta cells like insulin, NKX 6.1, MEF-A, and GLA2. And how about the encapsulation concept? Regarding the encapsulation concept, some considerations for the successful encapsulation should be achieved. The material should fulfill the requirements such as the stability, biocompatibility, and also the permeability. In stability aspects, the material should be generate as stable capsules, not swollen, and can prevent the cell leak out. While in biocompatibility aspect, the material should be having the ability to avoid extracapsular cellular overgrowth. And in the permeability aspect, the material should provide the ability of the nutrient and oxygen diffusion in and out, and provide immunostimulation properties. As I mentioned before, for the successful encapsulation, the material used for encapsulation should provide the ability to block the interaction between T-cell receptor from the recipients and the MHC from the donor, and also allowing the diffusion in of the glucose, nutrient, and oxygen, as well as the diffusion out of the insulin and IPC byproduct. In this study, the sodium alginate was used as encapsulation materials since it is easy to be applied and contain immunoisolation properties. And another thing that why we use the sodium alginate. The sodium alginate can support the cell viability and also enhance the differentiations toward the IPC. And how about the pluronic acid or pluronic encapsulation? The pluronic-based encapsulation was used as a double coating since it was non-toxic and also biocompatible and increased the angiogenesis. Let we see the chemical structure of material that we use. First, we're gonna see the alginate first. The alginate actually is an ionic polymer that contained manuronic and also the glucuronic block M and also the G block. In the normal form, the alginates, they will make a linear polymer that compose G block and M block subsequentially. Based on the study, many researchers mentioned that the G blocks play an important role as a gelling formation. When the alginate is extruded into the gelling solution, such as calcium chloride solutions, the gelling formation will be occur. The conformation of the alginate looks like egg box structure with the ion calcium in the center, making interlock in the G block. So that's why they can polymerize. While the pluronic is a copolymer 3 block that consists of 3 parts, 1 hydrophobic site and 2 hydrophilic sites. And the pluronic is a thermosensitive. In the cold conditions, they will be in the solid. They will be in the liquid phase, but in the room temperature, they will be in the solid phase. Then how about the encapsulation platform that we developed? The encapsulation platform that we developed will be around like this, with the alginate bead in the centers, and the pluronic as a double coating will bind in the surface of the alginate bead, and the hydrophobic sites will bind in the surface of alginate itself by covalent and also the hydrophobic bond. And how about the concept of the IPC encapsulation? The concept of the IPC encapsulation that we developed, we try to encapsulate the produced IPC by previous protocols by using alginate as a core encapsulation and double encapsulate or coating with the pluronics. And For the successful, again, the diffusion in and also the diffusion out should be achieved. For the diffusion in, the nutrient and oxygen and also glucose can penetrate into the capsules, while the secretory product like insulin and also the waste product of the IPC itself, it can diffuse out. And also this encapsulation platform should provide the immunoisolation ability. And we're gonna move about the research flowchart that we did, and how about the approaches that we use. Several approaches that we use is the first one. The first are for sure we have to establish the alginate-based encapsulations, and then we have to do a diffusion study, and then we have to evaluate the encapsulation platform, move to the IPC production and also the encapsulation, and finally we have to evaluate the encapsulated IPC. Let we see each step that we developed in our lab. In this part of the study, the device preparations and alginate bit production was performed. To obtain the alginate bits, the nozzle extrusion method was employed. It can be done automatically by the utilization of peristaltic pump. Here we can do it automatically, or we can just do it manually by hand. And the produced alginate here then be treated with the blue solution here. The blue solution here is a pluronic. I use methylene blue to make a color, to make a pluronic color. In the normal form, actually the pluronic, they are transparent and colorless. Okay, after we treat the alginate bit that we already produce, then treat it with the pluronic, then we will get the double coating platform encapsulation of alginate and also the pluronic. After that, we continue to the next approach. The next approach is a diffusion study. In this study, we use modified transwells diffusion assay. Normally, for a people with a cell culture work, they already know about the transwell. The transwell culture like this, or we just use the transwell culture and then modified the transwell with the alginate and also the pluronic, and put the solution and evaluate the solution under compartment, and we can get the result of the diffusion of the study. And to evaluate the diffusion study, we use glucose and also the insulin solutions, and to check the level of glucose and also the insulin. For the insulin, we use the ELISA, while for the glucose, we use a glucose oxidase assay to check the glucose level. And another evaluation of the encapsulation platform, we tried to encapsulate undifferentiated dental pulp stem cells, and then keep it in the media, and then try to evaluate the proliferation with the Alamar blue and also confirmation test with the live death staining. In this strategy, the human dental pulp stem cells was cultured. I think Dr. Chen Pop, Dr. Watchareewan already mentioned a lot about this. This one is just the IPC productions, starting for the culture of mesenchymal stem cells, and then doing the characterizations, and then doing the optimized protocol that already established in our laboratory. We just use the most simple protocol. We just use 3-stage differentiation or microenvironmental manipulations without any genetic modifications. After that, we evaluate the gene expression level measurement by RT-qPCR, and we did the functional assay by using the ELISA to check the C-peptide level, and also the ICC for checking the proinsulin and C-peptide as well. After IPC encapsulation was performed, the functional and viability assay of encapsulation IPC were performed in this study as well. The first evaluation, including the viability of the encapsulated IPC by using live death staining, and also we did a glucose stimulated C-peptide secretion assay to check the C-peptide level produced by the encapsulated IPC and checking by the ELISA. And also we try to dissolve the capsule by silencing agent in the citrate buffer with the silencing agent like EDTA, and the capsule will be dissolved, and then we recollect again the IPC and then check again the gene expressions related with the pancreatic marker, and also we confirm with immunocytochemistry study as well. Then how about the result? So for the first strategy, the first strategy is the development of the encapsulation platform. In this study, the alginate and pluronic concentration was determined. At that time, we use 4 different platforms. The first platform is 1.5% of the alginate and 20% of pluronics. The second platform is 2% alginate and also 20% pluronics. Another platform, 1.5 with 30% pluronic. And the last platform is 2% alginate and 30% pluronics. Let me see the result. The result was not satisfactory when we use 1.5 alginate and also 20% pluronic, because after double encapsulations, the capsule was break out. Then finally, we found the best concentration for the encapsulations. We found that 2% alginate and 30% pluronic is the best choice for this platform. Here is the result of our study, and the last platform that we did for the study. And about the biocompatibility study, actually the alginate 0.5 until 10% is acceptable. But in our study, we choose alginate 2% because it's preferable because they can provide the best cell viability. And also about the pluronic F1 to 7 that we use, actually we can use the concentration ranging from 20 until 40%. And if we use high concentration, it will have a consequence in shorter time in gelling formation. Actually, this consequence will be beneficial for us as the inventors, because we need as short as we can for doing the encapsulation. And for serving the IPC encapsulation, the diameter of needle, because in this study I use needle extrusions. I just use a needle that a usual needle that mainly used in the hospital. At the time, I use 22, 24, and 26 G needle, and the diameter of needle likely plays an important role. From this figure is visualized the effect of different size of the needle, starting from 22, 24, and 26 G size of needle on the diameter of the beads that we produce. And the measurement of the diameter was assessed at day 0, day 7, day 14, and also the day 28. The 22G needle resulted in highest diameter in both encapsulation platform, while the 26G resulted the lowest diameter size. What happened with this phenomenon? Let me see in the next slide. Okay. For doing the encapsulation, actually it's quite a simple technique. We can just use a nozzle extrusion method by using a syringe with a common needle that mainly used in the medical, in the hospital and private clinic and clinic. Okay, we just fill the needle, fill the syringe with the alginate solution, and then extrude manually. Can be done manually and also automatically by helping of the peristaltic pump, and then extrude the solution into the gelling solution. In this study, we use a calcium chloride solution and as a gelling condition. Okay, based on our study, no shrinkage was observed and slightly swelling without membrane breakage also was observed at the end of the experiment. This phenomenon might happen because the elasticity of the alginate as well as the high purified of the alginate that we use in this study, it have a beneficial effect to avoid the swelling. Then we're gonna move to the diffusion study. To evaluate the diffusion ability of the alginate and alginate pluronic encapsulation platform, we use the modified Transwell diffusion assay here. And this figure shows that the glucose and also the insulin diffusion in both encapsulation platform after 60-minute incubation. The result of this study show that both encapsulation platform of the alginate and also the alginate pluronic have a diffusion ability against glucose and also the insulin. In this slide, the figure A is the visualization of the encapsulated human dental pulp stem cell or undifferentiated cells. Morphology under inverted microscope. Based on this picture, we can see that the dental pulp stem cells were dispersed into single cells inside the alginate capsules. And then we did the viability assessment of post-encapsulation of the undifferentiated cells by quantitative method of Alamar Blue assay and also confirmed by the live data staining. Based on Alamar Blue assay, it showed that 48 hours post-encapsulation, the metabolic activity was slightly increased, while after 98 hours, the metabolic activity was relatively stable. And this result also consistent with the live data staining visualizations here. Why this study we use Alamar Blue? Alamar Blue is a redox indicator. Some researchers mentioned that Alamar Blue is more precise and reliable for 3D culture system evaluations. And with the Alamar Blue, the multiple metabolic reaction in both cytoplasm and also mitochondria can be assessed. Then how about with our findings? Our findings show that 48-hour post-encapsulation, the metabolic activity is likely increased. It might caused by the absorption of ion and also the protein exchange was slower due to the encapsulation. And another thing, the cell-to-cell communication was limited inside the capsule, and also the cell might need several time for adaptation. After 96 hours, the metabolic activity relatively stable. It might happen because the limitation of cell underwent to do a proliferation after the adaptations. And another thing that we have to be concerned is the cell will remain into the G0 stage. This result is just, I just want to show to you all about the IPC production. At that time, we use a human dental pulp stem cell as a model for the IPC inductions. Here is the characterizations of the human dental pulp stem cell. The figure is shows the morphological assessment of dental pulp stem cell under normal culture medium. They were performed, the plastic adherents and also fibroblastic cell were observed from these experiments. And then we also did we use a RT-qPCR to assess the proliferative the stemness genes, REX1, NANOC, and also OX4, and also the proliferative genes, Ki67. And we also did a flow cytometry to observe, to evaluate the surface marker of the mesenchymal stem cell. Based on this study, our cells was highly expressed CD90, CD73, and also CD44, while CD105 they are expressed but in a low number, and in CD45 the expression of the CD45 in our cells were extremely low because this protein is a marker of a hematopoietic marker. Dr. Watchareewan already mentioned about the induction protocol and about the result. And here are the results by using 10-day induction protocol that we use in this study. We just use 3-stage induction protocol starting. The initial differentiation was observed at the day 3, where the single suspensions of the stem cells at day 0 were changed into the cell aggregates or the cell colony. Further, in the development of cell aggregates were not at day 5, day 7, and day 10 at the end of the experiment. In the end of the induction protocol, big and dense cells aggregates were observed, and the total colony count of the cell aggregates obtained from this experiment were 424 until 581 per batch, colony per batch, in which more than 70% the cell aggregate had the diameter more than 100 micrometers, while small colony not more than 10%. In addition, we also check the cell aggregates with the immunocytochemistry method, and based on our study, the cell aggregates can express both pro-insulin and also insulin. In this study, the IPC differentiation was performed by using the simple method by microenvironment manipulations using small molecule that already well established in our lab. The initial stage of the IPC differentiation was the induction of the stem cells into the definitive endoderm. And in this stage, the combination between the activin A and sodium butyrate was used in the study. As reported by previous study, this combination of two molecules can induce the differentiation of definitive endoderm in adipose stem cells and also the human embryonic stem cells. And how about the next stage? The next stage is the pancreatic endoderm induction. In this stage, we use a physiological dose of the L-taurine. Because some researchers also already mentioned that the physiological dose of L-taurine can trigger the induction into the pancreatic endoderm. Finally, the last stage is the maturation stage. And that in this stage, we use a high dose of L-taurine, also nicotinamide, and the GLP-1. We use three molecules we use in this stage. The result of this study is consistent with a previous study performed by Abdel Alim that they conduct this research in 2015. And how about the cell aggregate with the size of the needle that we choose? As we can see here, the cell colony aggregates, we can produce 424 until 581 colony per batch with the diameter ranging from 60 until 300 micrometer. So that's why the 22G needle size is the most switchable, because the inner diameter of 22G needle size is 413. Why we have to choose the bigger inner diameter here? Because we don't want to break out the colony that we already produce. In this study, microscopic observation of encapsulated IPC in both encapsulation platform, alginate alone, and also the alginate pluronic acid. The findings show that the cell aggregates here were unequally dispersed. And for the analysis, we didn't see any aggregate damage during this experiment. And then for the analysis, we try to evaluate the viability of the encapsulated IPC under the capsules by using a simple method. We just use a live data staining and observe under the fluorescence microscope. Post-encapsulation staining showed that the encapsulated IPC were capable to survive at least 14 days in our study. However, if you can see here the red color here, the red color here it means the small mass of dead cells still viable in the core of the IPC. The pancreatic marker also was observed in this study by using RT-qPCR to analyze the expression of pancreatic endoderm, pancreatic islet, and also the pancreatic-related gene expression. In this study, as you can see, at day 7 and day 14 post-encapsulation showed that the encapsulation platform of alginate and also the alginate pluronic could maintain the expressions of pancreatic endoderm, like the NGN3, and also pancreatic islet marker, NKX6.1, MAF-A, ISLAT1, GLAT2, and also the insulin, and also the pancreatic-related genes, GLP-1, and also the glucagon. Actually, this one is the marker of alpha cells. Confirmation study was performed by using immunocytochemistry as well to detect the expression of intracellular insulin and proinsulin at day 7 and also day 14 post-encapsulation. The result of this study show that in both encapsulation platform in alginate and also alginate pluronic, intracellular proinsulin and insulin were expressed in day 7 and day 14 post-encapsulation. The similar expression of the intracellular proinsulin and insulin also was observed in mesenchymal stem cell derived IPC at the initial condition, meaning before encapsulation. And we also did the in vitro evaluation regarding the function of encapsulated mesenchymal derived IPC by using glucose-stimulated C-peptide secretion assay. These results of these experiments were compared with the initial condition of the mesenchymal derived IPC, meaning before non-encapsulated or before encapsulations. At day 14, post-encapsulation, the results show that C-peptide was secreted by mesenchymal derived IPC in both platform, in alginate and also alginate pluronic based encapsulations. When incubated under 22 millimole of glucose solution in crab ringer buffer, the significant difference was also observed when compared with the C-peptide secretion in a normal crab buffer and also glucose 5.5 millimole in crab buffer. And from this study, the qualitative in vitro viability assessment of encapsulated human dental pulp stem cells derived IPC in alginate and alginate pluronic acids was so that both encapsulation platform can provide switchable environment for dental pulp stem cells derived IPC. Another study on pancreatic islet cryopreservations incorporate with the alginate encapsulation reported that the alginate encapsulation could maintain both viability and functionality of pancreatic islet. And according to the functionality evaluation of the mesenchymal stem cell derived IPC that we produce here, in alginate and alginate pluronic acids, the result of this study showed that this encapsulation platform could maintain the expression of pancreatic endoderm and pancreatic beta cells genes marker at least 40 days that the time that we use in this study. In previous study, post-encapsulation induction by using human embryonic stem cell that conducted by another investigator, so that post-encapsulation induction by using human and embryonic stem cell could enhance both gene also protein expression of beta cells marker PDX1, MAFA, and also the insulin. However, in mesenchymal stem cell derived IPC, both the induction both in 2D and also 3D system using the alginate could produce mature beta cells as well. So based on our study, we can conclude that the alginate and pluronic acid based encapsulation technique can support the viability of dental pulp stem cells. And the consequence is the alginate pluronic acid-based encapsulation technique can serve as a transplantation platform of translational stem cell-based diabetes therapy using human dental pulp stem cells derived insulin-producing cells as a model. And we hope the finding of this study can be used as a scale-up prototype for translational stem cell-based diabetes therapy for both human and the veterinary medicines. And here is a published article. Actually, my presentations extract from these 3 published articles. If you are interested with this study, you can go and find this paper. And we already published in the Frontiers in Veterinary Science, in Journal of Biological Engineering, and also we just published in the Journal of Visualized Experiment. And in this journal, you can see the video as well, because this journal is accomplished with a video, maybe to make you understand how we did the induction protocols. And at the end of the presentations, I would like to acknowledge to my beloved, to Chulalongkorn University first as my second home for providing me a lot of research funding to accomplish my study. And also I would like to express my gratitude to my beloved advisors. My main advisor is Associate Professor Sayamon Sri Suwanata-Sakul, and my co-advisor is Dr. Chen Pop Sabangmek that already presents the topic yesterday. From them, I learned a lot and developed my scientific insight. And also for my senior, my mentor, and all of the team in veterinary stem cells and bioengineering innovation centers, faculty of veterinary science, Chulalongkorn University, thank you for valuable suggestions, discussions, guidance, collaboration, and for wonderful friendship. Thank you.
Thank you, Dr. Suryo. Yeah, for your third presentation in this Sunday session. Okay, now I invite Dr. Watchareewan and Dr. Chutirat to join Q&A session. Okay, I add spotlight to Dr. Watchareewan and Dr. Chutirat.
Hi.
Okay, thank you for all speakers in Sunday session webinars. And now while wait the question from participants, I remind to all participants, you can write your question in chat box, or you can ask directly using raise hand symbol. And now there is a first question from Professor Lucia. She is my seniors from Department of from Division of Veterinary Parasitology. The question for Dr. Chutirat. Yes, the question is, Dr. Chutirat has shared corneal stem cells. In addition, cornea, the retina is also often damaged, one of which is due to toxoplasmosis. Is your laboratory also working on stem cell for retina therapy due to toxoplasmosis, or has this therapy been implemented in Thailand? So maybe this is how the stem cells can be alternative therapy to treat maybe due to parasitic disease, Dr. Chutirat. Okay, what is your opinion?
Okay, thank you very much for the question. In my opinion, in our lab room haven't done about the stem cell in the retina yet, but in case of toxoplasmosis, in my experience, maybe we just try to treat medically, because of the toxoplasmosis can induce the severe uveitis and retinitis. Maybe we just try to use the anti-inflammatory drug, and that is in particular in the toxoplasma first. And if the About the retina stem cell, I think it could be used in terms of the retinal degeneration, for example, in the SAD, in the chronic retinal degeneration case, but it couldn't be used in the infectious case, as my opinion. Yes.
Okay. Okay, that's the.
Thank you, Dr. Chutirat.
Okay, is any another question, Prof. Lucia? Okay, it's enough.
Okay.
Okay, maybe I can continue the next question. It's from direct message. Okay, maybe this is related with the previous question for Dr. Chutirat. Maybe there is a study in corneal replacement use polymer hydrogel based like PLA, polylactic acid, or PLGA, polylactic glycolic acid. So it has biodegradable and biocompatible materials. So what's your opinion regarding your experience to use a polymer hydrogel based like PLA and PLGA to treat corneal disorders? Okay.
Actually, in the PLA and PLGA have a lot of the reports about that to use as the substrate for use to see the cell and transplant. But in my opinion about the biocompatible, if we try to use the natural substrate, it might be better than use the synthetic substrate. But it could be used. It could be, yes.
Okay. Okay, thank you, Dr. Chutirat. So I think, yeah, the hydrogel based, yes, it's very useful. Maybe it has any possible to replace the materials to treat corneal disorders. Okay, the next question. This is for all speakers. Yes. The question is maybe the question about the limitation in its study for Dr. Chutirat, Dr. Watchareewan, and Dr. Suryo. This is the question for all speakers. What is the limitation in your study? And of course, the potential for further study. Maybe there is some cell characterized, maybe can be revealed in the further study, and maybe there are many variables can be investigated in the next study. Okay, maybe for Dr. Watchareewan, you can answer this question.
Okay.
Yes.
So since last week, we have the proposal examination about the transplantation platform. And the committee also have like one concern also. And I think it's like one of the limitation of our study, whether when we like try to induce the stem cell, it doesn't mean that every cell gonna go into the Ipc or the insulin producing cells. So if we transplant them like directly, it can be called like the cell that not immature yet. It can like growing fast or called like the proliferation or something like that. And maybe can call like the teratoma in that position. So the way to solve this one, they suggest that about like we have to make sure whether the cell that we're gonna transplant, they are in the same phase or in the same cell type, something like that. Maybe like the flow cytometry or something like that. And another way, maybe about like the way we transplantation. If we have like in like Dr. Suryo like presentation that we encapsulate or have like some like put in the pocket, it may be like help to prevent the leaking of the cell also. But it's just still the ideal. So we're gonna see maybe like Dr. Chenpo has mentioned yesterday about that we're gonna trial this platform and get the result maybe in next years. Yeah.
Okay. Okay. So how about Dr. Suryo? What is your limitation study, or maybe there are many issue that you can observe or investigate it for your further study? Hello, Dr. Suryo. Okay, maybe Dr. Suryo unstable connection. Okay, so how about Dr. Chutirat? Okay.
Yes.
Yes.
Okay, sorry.
Hello.
Okay.
Okay.
Dr. Surya, okay.
Can you hear my voice?
Yes, clearly.
Okay, so sorry for the unstable connection. Okay, I agree with Dr. Watchareewan. She highlight about the efficiency of the inductions. Yes, we have to consider about that as well, because we just try to mimic the natural environment in vitro setting, but based on our knowledge, based on our study, because my study is focused on the transplantation platform. As you can see, maybe you can realize that all of our study is just conducted in the static conditions, which is not quite good to get the real condition in our body. Actually, we have in vitro setting, we can do more study with the dynamic static. We can use like a microfluidic to check our encapsulation platform first, how stable the bead is, and then the efficiency of the diffusion, the efficiency of the production of the insulins of the encapsulated IPC inside the bead. And for sure, my study is far away for the clinical transplantation because I don't have enough time to do all of experiment in Chulalongkorn University. And I believe my junior will continue our projects. If I'm not mistaken, some of students under Dr. Chen Pop supervised under Dr. Chen, but also did the same platform and try to escalate this study with the animal model as well. So maybe if I hear the result from them, we can invite them to present in our maybe next webinar. We can invite them to update the progress. For sure, our study is still far away for the clinical transplantation, but we try to find the strong evidence, the strong scientific evidence from our platform that can be applied into clinical applications. That's all.
Okay. Okay, I think it's very interesting if we can invite again the progress about the study in the further session webinars. Okay, how about Dr. Chutirat? Yes, what's your answer?
For my study, I have a lot. I have a lot of limitations. The first is the sample. It's very difficult to collect the sample because in the dog cornea, I should get the sample immediately. That will get the face cell. So it's like very, very difficult to find in that case. And the second is about the corneal engineering. It takes quite a long time. In my experience, I take at least 14 days, and in some cases 14 days some corneal is completely healed by itself. And the first is the transparency of the corneal engineering. Maybe in the next study we can try to use another substrate that's more transparent and biocompatibility, for example in the collagen and something else. Yes.
Okay.
Thank you.
Okay, thank you, Dr. Chutirat. Yeah. Next, yes, from the chat box, I get a question from Dr. Gracia. Yes, for Dr. Watchareewan. Okay, like the chat box. I would like to ask the second speaker, Dr. Watchareewan. that do IPCS cells colonies have an expired date in vitro, and how long can IPCS cell colonies survive in the recipients? Okay.
So for answer the first question about the expiry date in the in vitro, so let's say that for like, actually for my research, I didn't like culture them for a long day, but from our colleague, also like from Dr. Suryo and another master student. For the master student, we have two things that we have to concern about. For the first one, if you like culture the IPC, that's just the colony of the IPC itself, it will like after the induction, not more than 1 week, the colony cell will be like dispersed and attached to the low attachment dish. However, if we use like the alternate encapsulation like Dr. Suryo did, it can like keep for more than 2 weeks. But I'm not sure about how long that Dr. Suryo had keep it, but they're still able to. And then for the IPC in the recipient, I'm not sure in the IPC itself, but from like the Edmonton Protocol that they transplant the eyelid extraction, they can like remain the blood glucose level in the patient maybe like 1 or 2 months. But in the end, it cannot like for the lifelong for sure. We have to like retransplant or do something more about this one.
Okay, Dr. Suryo, can you add some information maybe?
Yeah, sure. Actually, I agree with Dr. Watchareewan opinion. Yes, for the IPC that we produce, we still didn't know a lot about the behavior of the IPC itself. Like Dr. Watchareewan said, if we just maintain the IPC without any encapsulation, she mentioned that they just can only live for 1 week. But based on my study, I use only 2 weeks to keep the IPC inside the alternate capsules. But I believe it can be used. This basic information it can be useful because as Dr. Watchareewan mentions, another team in our labs also use a similar study and prolongs the evaluations into a more time, and we hope we can keep the IPC inside the capsule for a longer time. But based on some paper that I found and that I read, they use human embryonic stem cells and also human adipose stem cells, and they try to encapsulate as well and transplant into the animal at the time. I'm not sure they use a pig or the dog. They can maintain the blood glucose at least for 3 months, but the limitation of that study is they just make endpoint of that experiment only 3 months. But we have to maybe for clinical practice, we have to monitor the blood glucose as periodically when the animal so the diabetes mellitus signs again. So maybe we have to retransplant as Dr. Watchareewan said. But we are not sure about how long the age of the IPC that we produce. Thank you.
Okay.
Oh, can I add one more thing?
Yes, of course.
So now actually in our lab, we also develop on the media to maintain the IPC property. We started study from the eyelids, the extraction eyelid from the mice also, and they can like the media that we trial, they can keep like more than a week or 2 weeks also. But it's still study and gonna like probably soon, I think.
Okay. Okay, thank you, Dr. Watchareewan and Dr. Suryo for your answer. Okay, next question from Julia for Dr. Chutirat. In your presentation at all experiment was on dogs, are you get or maybe you get case in cats because most kitten got this ophthalmic disease. So did you use your regenerative therapy stem cell used in cats, not only in dog? Okay, Dr. Chutirat.
In my study, I used in the dog cells only because we would like to make a model to generate the corneal regeneration. So maybe in the future, we can try to step on the cat cell as well, because I think the anatomy of the cat eye and the dog eye is not much different, and about the cell is still under experiment. If we try to use the cat cell, maybe we going to be the first person to discover the cat stem cell in the cornea. And I totally agree with you about the ophthalmic disease in the cat. It's usually neonatal disease, and sometimes it's get like a herpes viral infection. And nowadays we still have a lot of the treatment medically in the cap of ophthalmology too.
Okay. Okay, thank you for your answer, Dr. Chutirat. Okay, next question for Dr. Suryo about the bead production during your study. Okay, maybe this question is how about the methods to produce a bead? Is it similar to produce bead using electro spoon, or it different with your methods, or maybe maybe which one better to produce bead using electro spoon or like your methods? Okay, Dr. Suryo.
Okay.
Okay.
Okay, regarding the electrospan, yes, it's quite similar with the protocol that we use. So I mentioned before, I just use a manual extrusion method, which is the simple way. In electrospan, actually, the basic principle is quite similar. They just use a syringe. Yes. And also the needle, and then give some electrostatic, some electric, and then they use like a cylinder, and then capture the alginate solution on that. Yes, we can do the same way, but at that time I tried to propose to my advisor, but he said we can try the basic concept first to prove that the IPC can survive and can functional inside the capsule. So maybe in the future we can enhance that protocol. And actually, in our result, it's not quite ideal, because when we use a manual extrusions, as you said in my presentation before, in one capsules we can get more than one IPC, and its capsules we couldn't control how many IPC that can come inside the capsule. So it will be difficult to control the number of the IPC in one bead. And ideally, we have to find the method how to encapsulate one IPC in one bead. Yes. And one of the approaches that can be we use is with the electrospans. Actually, the same method, we can just use our syringe and let's put the electric, and then we use the gelling solution. We can use a calcium chloride and also barium chloride, but we have to consider many things, because with electrospan, it will be looks like the solution will be forced in the high speed, and also they have electric field as well. So we just concerned about the viability of the IPC itself, but we can try to do the electrospan method to encapsulate the IPC.
Okay, thank you, Dr. Suryo. Okay, maybe this is the last question for Dr. Chutirat. Is there any side effect during your study in corneal regeneration? Okay.
Sorry, could you repeat again?
Okay, is there any side effect during your study in corneal regeneration? Maybe there are some side effect after corneal replacement or corneal implantation. Okay.
Okay. In my study, I didn't do in vivo. I just try in vitro. But in the previous study, they have some side effect about the graft rejection. Yes. Because sometimes the cell is not compatible on the host to on the donor to the recipient. We need to actually in the previous report, we try to use the autogenic cell first, and I think in the future, if we would like to use the allogenic, we can repeat just only the layer of the stroma, because the layer of stroma, the stem cell, is that kind of mesenchymal stem cell that have the possibility to transplant allogenic. Yes.
Okay. Yep. Thank you, Dr. Chutirat, for your answer about your study. Okay. There are no any question. Okay. I think it's enough. Finally, we come to the last agenda. Thank you for all speakers for your willingness to join in our webinar session in this Sunday. It's a weekday for your a long day. Okay, now I will present electronic certificate, a certificate virtually for all speakers. Let me share screen certificate. Okay, wait. Okay, the first certificate we dedicate for Dr. Chutirat Torsahakul. Thank you for your outstanding presentation in this webinar. Thank you, Dr. Chutirat. And the second certificate we dedicate for Dr. Watchareewan Rodprasert. Thank you, Dr. Watchareewan, for your willingness. And I wait for your further report, maybe your experience in the next webinar with Dr. Suryo and Dr. Chutirat, and also with Dr. Chenpop and Dr. Sirirat. And the last speakers, the last certificate dedicated for our senior, Dr. Suryo Kuncorojakti. Thank you, Dr. Suryo, for your presentation in the last session in this webinar. Okay, thank you. And now we are really delighted about your sharing and having your experience. Thank you. And now I return the ceremonial session to our Master of Ceremony, Dr. Debbie. Please, thank you for your nice little opportunity to having me on your webinar session. Thank you, Dr. Debbie.
Thank you, Dr. Tohawi. Once again, thanks to all speakers who are willingly sharing us their knowledge to all of us. I believe everyone in here must be satisfied with the materials as well, since these are very useful for all of us in here. Hopefully, this webinar will be fruitful for all of us in the future. And also, before I'll close the session, I'd like to greet our Honorable Vice Dean in Academic, Dr. Rimayanti, and also the Honorable Head of Veterinary Science Medicine, Professor Wijiati, who are also joining in this session. And to close our session for today, I'd like to invite Dr. Rimayanti, our Vice Dean in Academic, to give us the closing remark to close our session, our international webinar. Is Dr. Rimayanti here?
Yes.
Okay. Yeah, Dr. Rimayanti, time is yours.
Thank you, Dr. Debbie. Yeah. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. First of all, I would like to introduce myself. I'm Dr. Rimayanti as Vice Dean of Academic, Student and Alumni Affairs, Faculty of Veterinary Medicine, Universitas Airlangga. Let us praise and thanks to Allah Subhanahu wa Ta'ala for the abundance of His grace and the joy to all of us, so we can still gather this morning in such good health. In this very good occasion, I would like to thank our speakers for today's update on veterinary stem cells. That was for Associate Professor Dr. Chen Pok Sawang Mik, DVM, Master of Science PhD, and then also for Dr. Chutirat Torsahakul, DVM PhD, Dr. Chutirat Torsahakul, DVM, and then Dr. Watchareewan, Rodprasert, B.Sc, PhD, and of course, Dr. Suryo Kuncorojakti, DVM, M.Vet, PhD. Thank you very, very much for enlightening and interesting lecturers. All of us have obtained a great knowledge and discussion. We have learned a lot from the lecture session, delivered by amazing lecturers who have shared their interesting experience. On behalf of the Faculty of Veterinary Medicine, Universitas Airlangga, and the committee, thank you for delivering such important topics so all of us can deepen our knowledge. We really, really appreciate that. Thank you very much for also moderator in the 2 days, Dr. Suryo Kuncorojakti, DVM M.Vet PhD, and also Dr. Muhammad Tohawi Ziyad Purnama, DVM Master of Science, and of course, our Master of Ceremony, Dr. Hugelain Debbie. I would like to thank all participants who have joined this guest lecture. I hope it can gain our knowledge about stem cell in veterinary field. Finally, I would like to thank the Division of Veterinary Anatomy of Faculty of Veterinary Medicine, Universitas Airlangga, chaired by Dr. F.P. Muhammad Lukman, and all of the lecturers in the division for organizing this event and ensuring that it proceeds and running smoothly. I hope we will be able to meet with all speakers and participants in the next event. Thank you very much. Good morning and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Dr. Rimayanti, for sparing your time and joining this webinar. A very nice closing remark. It's glad to have you here with us all. And yeah, so on behalf of the committee, I would like to express my gratitude to the Honorable Dean of Faculty of Veterinary Medicine, Universitas Airlangga, Professor Dr. Mirni Lamid, and then the Vice Dean of Academic, Dr. Rimayanti, DRH Ankes, the Vice Dean of Finance, Dr. Iwan Sahrial Hamid, the Vice Dean in International Affairs, Professor Mustafa Helmi Effendi, and the Honorable Head of Veterinary Science Department, Professor Wijiati, the Honorable Head of Divisions in the faculty, Dr. F.P. Muhammad Lukman, and all speakers that have shared their experience and knowledge since yesterday's session until today's session, the Assistant Professor Dr. Chen Pok Sawang Mik, DVM Master of Science PhD, Dr. Chutirat DPM, Ph.D., and also our speakers for today, Dr. Chutirat Torsahakul, DPM, Dr. Watchareewan Rodprasert, Bachelor of Science, Ph.D., Dr. Suryo Kuncorojakti, DPM, M.Vet, Ph.D., and our moderator for today, of course, Dr. Tohawi. And yeah, so that will be the end of our event for today. Also, thanks to all committees and participants who have joined this webinar, this two-day international webinar session. And once again, thanks to all of you, to all speakers, moderator, participants, and all parties who have supported this event so this event can be held successfully. And forgive me for my shortcomings, and see you next time. Stay safe and stay healthy. Wassalamualaikum warahmatullahi wabarakatuh. Have a great day.
Waalaikumsalam. Thanks to the organizers and the presenters.
Thank you.
Thank you. I don't know. Thank you all.
Ya, terima kasih.